Yes, and I'm actually going to speak without slides because I hope that my first the presenters before me have already shown excellent data, and a lot of it is actually what I just want to expand on, and that we can hopefully have a really interactive discussion after that as well. So, especially thank you, Katja, for showing these slides because I think this is exactly what I wanted to focus on a little bit more. I think you already Jennifer, you mentioned the importance of getting to an expert and getting the right diagnostics. Now, uh, I think the topic of addressing high risk myeloma appropriately is we're only seeing the start of this, and the reason why we're seeing the start of this is that we are seeing this improvement of treatment options. You've heard about all the exciting options that we will see, hopefully in the near future, much more of in terms of the T cell directed therapies. But as we could show, the German group could show, us in our Optimum trial, and the German group in the Concept trial, is that we can safely combine up to 4 or 5 of the drugs now that have been developed over the past years together to actually improve efficacy of the treatment, to improve intensity, and maintain the tolerability of treatment. But I think, why is it so important that we get the right treatment to the right patient? Well, first of all, of course, there is the high unmet need in high risk disease. And what we are also now increasingly trying to eliminate is that there is a ultra high risk disease group. So unfortunately, myeloma is a disease that tends to relapse, but there is actually a wide range, as many patients will know, of intervals within the disease can relapse. And it's probably not really adequate for patients, physicians, and the whole treatment plan to just speak of high risk or non-high risk disease. But actually underlying this are different genetic changes. And the myeloma tumor cells, all of them will have some genetic changes for the disease to start in the first place, but it will accumulate more of these over time. And we can nowadays actually look and through relative information from the combination of several genetic factors, and for example, identify those patients that have 2 or more high-risk markers as having ultra high-risk disease, or being at a much higher risk than others of seeing their disease relapse really early if treated with normal standard treatment. So I think this is getting more and more important, that we get the information from, for example, genetic analyses. And there are, of course, different other factors of risk as well, such as the age of the patient, the frailty of the patient. But these might need different ways of addressing. If we're thinking about the molecular makeup of the disease, we pretty much know that an intensification of treatment is probably the right route to go. Whereas if we think about frailty as a marker, it can actually be de-intensification of treatment. So giving less can be more for these patients. So it's really important to get right as to what we mean by risk and what the could be in terms of treatment adjustment. And that's really where expert centers, of course, have an insight, but also an obligation to distribute that knowledge further into the community. And I think that's what we're all trying to do when we're doing these studies. So just coming back to the molecular risk and ultra high risk, I think this is something that in the data that Katja Weisel just showed from the Forte study came out really clearly as well in retrospective analysis, looking back at older data sets or just recently generated data sets. Like the Forte study, it is becoming clear that also there, those tumors that have 2 or more high-risk markers, and by this I mean, for example, a translocation 414 and a gain of 1q, or let's say a gain of 1q and a deletion 7p together, these were the patients that were at highest risk of relapse if they only received standard intensity treatment. So that we can adjust now treatment and give these more intensive treatment to patients that have high risk is, of course, a very positive thing. And I think the data that you've just seen is really encouraging in that we can improve outcomes for these patients. We do need to do more, that more of such treatment is available to therapies for ultra high risk disease. But I think looking ahead, The other aspect that will be really important is we're seeing these treatments emerge that you've seen in the beginning, that are BCMA targeting, for example, or targeting other surface markers of the myeloma cells. But what they will have in common is that they will inevitably, unfortunately, to an extent, also target healthy plasma cells, healthy immune cells that can help us, our body, defend against infections. Now, we will probably be in a position where we can combine a lot of those together because the general side effect profiles are quite favorable. What we might increasingly see that we are maybe exposing our patients more to risk of infection the more we deplete the healthy plasma cells as well. So it could be particularly important that in the future we get the intensity of therapy really right for patients, because no one doubts that the response rates and the remission times that we see with these treatments might be unprecedented. So as Niels van Dong actually said, is it's a one-off treatment potential with CAR T cells. And if this might be given to a patient with a standard risk myeloma, it might be that that is the treatment that they need for the next 3 or 4 years. And actually that's hopefully then going to be the least affecting them in terms of side effects as well. So really discriminating the different groups of risk, I think, will be really important, not only for the ultra high risk group, but maybe also for the other patients in terms of making the treatment as tolerable and as compatible with an excellent quality of life as possible. And I think the chances are never better than they have been before with all of these treatments emerging. I just want to focus as well a little bit on that there are other molecular markers that have emerged, not at this ASCO, but at ASH last year. There was an update, for example, on patients with T1114 benefiting from the combination of venetoclax and Velcade, which had a question mark above it in terms of safety before, but this has really been addressed now, and it's clear that these patients are benefiting. I think it's great that a lot of patients may have access to that already, but we're very, very much hoping that there is an approval coming through as well formally, so that even more patients can benefit from such treatment that's really adjusted to the genetic makeup of the disease. And likewise, there was a very exciting presentation on patients that have tumors with a so-called BRAF mutation, so a mutation in a gene that is very well known in other cancers to drive the disease. So for example, in skin cancer, BRAF is one of the key driving genes. Only 5% of myeloma patients have this mutation, but the treatments that are now being developed in melanoma, so in a skin cancer, they have been shown at ASH to be effective against myeloma that is driven by this type of mutation as well. And I think we hope that over the coming years, we get more and more cross-fertilization, as we call it, from these other diseases. There is so much development going on in oncology and tumor treatments overall that we hope that we get, apart from these treatments that are very specifically developed for myeloma, also benefits from treatments that are targeting specific mutations that are common across different tumors, including myeloma. Now, something in the realm of diagnostics as well that I wanted to just mention is we had the pleasure really of presenting our results from a study in which we compared new novel imaging methods. So this is really mostly credit to our amazing radiologists who have been developing MRI for myeloma in a completely new way that it was not available 5 or 10 years ago. It's called diffusion-weighted MRI, and they have defined, we were part of a big international initiative, international guidelines on the how to acquire these images, how to report them, the so-called MIRAT criteria. We were comparing those against standard PET-CT imaging, which I think, especially in the US, is the most commonly used imaging method at diagnosis of myeloma. And we did find that the whole body diffusion weighted MRI, as it's called, really picked up disease more sensitively. So it found smaller areas of disease. It found more areas of disease that were effectively the PET-CT was blind to. And in particular, it could pick up what you call diffuse disease, where the myeloma cells are spread out across the bone marrow instead of growing in lumps, much more sensitively than the PET-CT scan, to the extent that those patients that had disease on the MRI scan also had higher paraprotein levels. So we could quantify the disease by the imaging, which is very common in all other cancers, but in myeloma has not been the case before. So we're really continuing to work on this and using this in trials now for imaging MRD as well. I hope it will be a real benefit for patients moving forward because it does not require injections. It's an imaging method without radiation exposure. And what we are finding, this increased sensitivity where it gives us a benefit because we can use it as a standard imaging method across the patient journey, is not only a diagnosis, but where we find it particularly interesting is, or useful really for the patient, reassuring as well, is at relapse, where we can see if the paraprotein rises a little bit or the light chains, can we already pick up disease by imaging? If not, maybe it is safe to wait a little bit longer until we start the next treatment. We all know we don't want to wait for patients to develop symptoms again, but with such an imaging method like that at hand is really making things far, far easier and better. And I think as the last thing I would probably mention is that there were two really nice summaries at ASCO and EHA, one by Dr. Costello from San Diego, for example, where she really highlighted how much the introduction of daratumumab against something that Katja showed has made a big impact and is still making an impact in terms of practice changing for our patients. Now, the real progress with daratumumab has been, and I hope we're seeing more of that, is that it is now a subcutaneous injection. And she made the point that we should really be doing more to make this treatment deliverable for patients in the community, to really reduce the need for visits to hospitals. And I think we are lucky, again, we have a very good pharmacy and nursing team at our hospital, but I think lots of other hospitals are taking this forward in Europe now as well, that we have community nurses that go out and administer the daratumumab at home. I think this is something that we should really push for as a community to make treatment for patients much, much better. And I think she made the right point. In rheumatoid diseases, administration of TNF-alpha inhibitors have been a standard now in home delivery. Why should this not be the case for myeloma? I think along these lines, there was also a very nice summary on these new T-cell targeted treatments, because I think this is something with all the excitement that we see about their activity that we need to see emerge over time still. They are safe, and I think we're all amazed by how safe they are, but I think we are still probably a little bit early in really determining as to where they will be administered in the future, because there is still a risk of some patients developing severe or higher grade cytokine release syndrome. So it will really be something that we will have to watch very closely, whether these treatments will still require short inpatient stays, or at least patients living close or staying close to hospitals for quite some while. And that might be the trade-off to do in terms of achieving that high efficacy, but there might still be patient populations where we might, for example, want to consider treatments like belamaf, which is an antibody that's already licensed, that is not having these cytokine release syndromes and still targets BCMA. It has other side effects at the moment with eye toxicity that have to be taken seriously, but might actually improve with different ways of giving the drug in the future. And I think all of these things will play into what is the deliverability of our treatments. The deliverability of some of the drugs I've seen is amazing, like daratumumab, for example. And for other treatments, I think we will really, again, need to see the theme emerge much more about which treatment will be given to which patient. How can we tailor our treatments the best way to address the needs of the patient, both from the side of the biology of the disease, but also the requirements or the personal wishes of the patient, really, about how treatment should be delivered, because we are seeing certain themes going through. There are certain requirements, of course, for patients to stay on treatments to control disease optimally that we have seen over the years, although CAR T-cell therapies might give a different aspect. And the more we learn about how these therapies work, the more we can adjust to the patient needs in the future. With that, I want to come to a close, and I hope that we will have a really good discussion about all of these things.